Good afternoon, everyone. And on behalf of the Clinical and Translational Science Collaborative of Cleveland, we welcome you and thank you for joining us for our READI Community Engagement Series, Equity and Engagement Talk, focusing on building relationships with community health workers to advance research. Before we begin, we'd like to share a bit about the Clinical and Translational Science Collaborative of Cleveland, or CTSC. The CTSC is a collaborative among Case Western Reserve University and its affiliated hospital systems, the Cleveland Clinic, MetroHealth, University Hospitals, and the Louis Stokes Veterans Administration Medical Center. We aspire to be a catalyst for high-quality clinical and translational research, both locally and nationally, by changing the culture and environment of biomedical research, sharing resources and expertise, and streamlining the research process to move translational research from bench to bedside and to the community. Today, we'll hear presentations from Odiri Omobien, Community Health Manager at University Hospitals, Jennifer Conti, Manager of Population Health at the MetroHealth System, Marie Velez, Pathways Hub Project Lead and Supervisor of Better Health Partnership, and Elisa Sprague, Coordinator of Mental Health Intensive Case Management for Veterans with SMI at the Louis Stokes Veterans Administration Cleveland Medical Center. And for our agenda, we will have our presentations first, and then we'll do Q&A after that. Here are our experts, and Odiri, the floor is yours.
Hi, everyone. Thank you so much again for having me on today. I'm really excited to have this talk with you all, and I'm looking forward to all of your questions. So I'm just going to get my slides queued up. All right. So again, my name is Odiri Omobien. I am a licensed independent social worker with a supervisory credential here in the state of Ohio. Previously, a lot of my work here at UH centers around working with our community health worker program. I had the privilege over the last 2.5 years to design and implement that, that program and scale it up to the program that it has become today. So extremely privileged to have been able to do that work, and hopeful to be able to shed some insights on how researchers and particularly can build relationships with community health workers to advance research. So I'll start off by level setting as to what a community health worker is. And we're going to hear this definition multiple times throughout the presentation, but I think my biggest takeaway from what a community health worker is they bridge the gap between healthcare and the communities by being experts in chronic illness and social barriers. It's important to keep in mind for context that community health workers have been around for decades. I think now they're just becoming more professionalized, if that's even a word. I'm going to make it one today, but professionalized and the spaces that they are in. So we're seeing managed care organizations want to work with community health workers. We're seeing hospitals, community-based organizations, and so on wanting to work with community health workers. I think it's also important to understand that within context, community health workers, sometimes you might hear that term interchangeable with patient navigator. Working in a hospital system, I know that patient navigators have a slightly different function from a community health worker in the healthcare space. But I really want to emphasize that community health workers are a profession within its own right. Governed by the Ohio Board of Nursing, they are certified individuals that are actually being trained in this specific niche of work. So I really want to emphasize that as we move along in our presentation. Something that's really unique about our community health workers at university hospitals within care transitions and inpatient rehab is that the community health workers are trained across a variety of settings and actually have a really broad, full spectrum of knowledge of patients' needs within the community setting and in the clinical setting. Something that we really prided ourselves on when building up this program was to make sure that the community health workers were serving the sites that they are placed at the level that the site needs that type of support. So if we have a community health worker that's working in the advanced behavioral health space, working with individuals that have a chronic illness and a chronic mental health diagnoses, being able to have that community health worker travel out within the community and meet those individuals at other appointments, maybe at a different institution, maybe at the library, wherever it fits for that patient to be have their needs met, that's where we have that community health worker going, versus a community health worker that's working in a primary care space or at our Ahuja Women's and Children's Center, being able to be centrally located to be able to support high-risk patients that are coming to their doctor's office or their provider's office to do routine care, or to connect them with some resources that are centrally available depending on the location that they're at. So something to keep in mind is that community health workers, when it comes to research, because they have such a broad spectrum of work that they, of knowledge that they have in different settings, making sure as researchers that knowledge is being leveraged appropriately. So about our community health workers, we have 25 certified community health workers within the system across all of these different sites that you see on the left-hand side of the screen. Our program is workforce development based, and I will get into that in our next slide, but our program is workforce development based. And within that, we have had the privilege over the last few years to have individuals that would like to be certified as community health workers in the state of Ohio join our team. We train them, we get them certification, we collaborate with our job readiness collaborator towards employment. And we teach them the soft skills, we teach them the skill set of a community health worker, and also partnering with Tri-C as our educational collaborator. We teach them the skills that they need, and then we partner them at the sites with certified community health workers that have already gone through the program in years past. It gives everyone the opportunity to teach and be taught. It's an apprenticeship model, and I'll get into that in the next slide, but it's been such a wonderful return on investment, seeing individuals grow themselves professionally. We've had multiple people that have had the opportunity to work in research spaces, such as our HIV or HCV focus program and our Achieve Greater program, being able to work in these research spaces and understand how research is functioning, and then the researchers get to understand how community health workers function. And then just a little bit about our workforce development programming. So using the work advance model, being able to collaborate with Towards Employment and Tri-C. This is a very special program because this is the way that UH is pouring back into the community, right? Providing job opportunity, providing accessibility to, be able to move from community health worker to a social worker if you want, providing that exposure, being able to move from a community health worker to a nurse if you want, to provide that type of exposure, allowing people into the hospital system and getting them the access that they need, the resources, the education, the connections to be able to bolster themselves up. It's been truly a joy to be able to work with Towards Employment, to be able to work with Tri-C, and provide that supportive coaching and mentorship to all of our applicants, all of our apprentices that have come through the program, and seeing how that return on investment has continued to grow over the years. The biggest takeaway that I think I could leave here for us to think on is how researchers can build a relationship. It's important to understand the scope of practice of a community health worker and provide advancement opportunities within the research community for community health workers. Community health workers are not inexpensive labor. That is not what community health workers are. Community health workers have a profession. They are board certified in some spaces, and it varies based off, the state that you're in and what states have what governance is in place. In the state of Ohio, the Ohio Board of Nursing governs community health worker certification. It's important to know that community health workers can collaborate on research implementation. They serve as excellent supports to research participants, making sure that the people that are participating in the research are also having, return on investment for themselves. So they're not just participating for us to be able to have data to collect, but they're also having their social drivers of health met. They're also getting their resource. So somebody that needs transportation can have that connection. Someone that needs, connection to a primary care doctor can have that connection. Food insecurity, they can get that connection. Community health workers are excellent in those spaces among many other spaces. I think another really important piece too is health literacy translation. So being able to speak to the populations that researchers want to do research in, particularly in the Black and Brown communities, being able to have a community health worker that can dissect some of the information that you're going to be presented with, be able to dissect that and translate it for you so that you can understand this is what you're actually getting yourself into, this is how it benefits you, this is what's going to happen with this information, and just having that trusted partner go along with you as you journey. I think another really important piece of having community health workers work within the research realm is building individual and community capacity. That is so important to not just as researchers seek to research and study a certain population, but also build up that community, build up that individual's capacity, giving them something to take away from the research that they are participating in, and how a community health worker can help with that is, making sure that person understands how to maintain whatever it is that they are researching. So when we think about our HIV and HCV focus program here at UH, having a community health worker be able to support you as they connect you to our special immunology unit after you've, received this information that, now you are, HIV positive, or you have, a hepatitis infection, being able to connect you to that SIU clinic, support you along the way, help you understand this is what this diagnosis means. This is how you're going to take your medication. Here's who you're going to connect with as we work through this treatment plan that you now have, and supporting that individual. So that way, when they are able to be stabilized, right, that person can come away with information, they're empowered, they understand what their chronic illnesses, and they can take away from that the opportunity that, they have a support system. And then ultimately, I'm a big fan of lifting as we climb. So being able to pour back into the community and spread awareness. Community health workers are essential when we think about doing community-based programming, health fairs, being able to have screenings out in the community, making sure that community health workers at the root, they are individuals that serve the communities that they come from. And so being able to have someone that knows what the needs are in your areas, a trusted person that can help you navigate those spaces, identify your own needs, and then bridge those big gaps in care, I think that is essential. So I'm interested to see what others have to say as far as how researchers can build relationships with community health workers as we go along. And I think the last point that I'd like to make is making sure that there's advancement opportunities within the research. Advancement opportunities beyond, just maybe collecting data, but also being able to collect data and having community health workers at the table to understand the data that's being collected and why that data is important, and positioning them to have career advancement in other areas. I think that's really, really important. Training them the way that the research informs them to be trained. Community health workers are, not auxiliary support in the event that something, someone doesn't show up for, to schedule calls or anything like that. They have a specialized certification to be able to do all these things, but and many, many more, but really being able to help advance their profession and advance the community health worker. I think that is essential to building relationships. So I'm going to stop sharing. Angelise, I'll hand it back to you.
All right, thank you so much, Odiri. Now, Marie and Jen, you are up.
Thank you. Let me get my slides ready. Can everybody see my slides? Okay, perfect. So my name is Marie Velez. I am with Better Health Partnership. I am the Pathways Hub supervisor for what we call a network of care coordination agencies that decides to adopt the Pathways Hub model for their CHWs to complete their work. So I'm going to be talking to you about what the model is, what is a Pathways Hub, and how do we use it to advance research. So yeah, this thing. Today, like I said, I'm going to be talking to you about Better Health Pathways Hub and how the CHWs in our hub have helped advance research and continue to do so. For those who don't know what Better Health Partnership is, our vision is to be the region's most trusted health improvement collaborative, achieve exceptional health value, and eradicate health disparities in Northeast Ohio. Our mission is to bring healthcare providers, social services, and other sectors together to share best practices and accelerate data-informed improvements in equitable populations and community health. So what is the Pathways Community Hub? The Pathways Community Hub is an organized, outcome-focused, and pay-for-performance network of community-based organizations that hire and train community health workers to reach out to those at greatest risk. The CHWs identified risk factors and barriers and assure connections to medical, social, and behavioral health services. The goal of the Pathways Community Hub is to improve health, reduce costs, and promote health equity. So some of the benefits of the Pathways Hub are that it strengthens linkage between social services and healthcare providers to better coordinate care for at-risk populations, bring sustainable revenue to community care agencies from Medicaid managed care plans via reimbursement, and provide employment opportunities for CHWs via care coordination agencies. Our hub also provides professional development and peer support network. In Ohio, we have around 14 certified community hubs providing care coordination for Ohio's most at-risk individuals. There's about 192 CHWs serving hub clients in Ohio, and around 65 care coordination agencies that employs community health workers. Or model structure, I like to say the hub is kind of like the glue in the middle that keeps the care coordination and the managed care plans or funders together. We coordinate contracts with the care coordination agencies and payers. We facilitate payments for the care coordination agencies for the outcomes achieved for the work that the CHWs complete. And we also manage the referrals for the care coordination agencies. And we also provide professional development for the CHWs. Our certifying agency, the Pathways Community Health Institute, likes to define the work the CHWs do through the model as find, treat, and measure. CHWs and hubs identified at-risk individuals. A CHW is assigned to help improve the well-being of that participant by providing care coordination services to address their social and medical needs. In the process, the CHW teaches and reinforces healthier behaviors to the people they serve. Or funding model, after the CHW works with their clients or participants, through the care coordination agency, the care coordination agency is paid based on outcomes achieved, meaning the CHW help that individual meet their needs and mitigate the high risk. The model then reimburses for pathways successfully completed. So what is a pathway, right? So pathways are step-by-step care coordination tools that addresses an individual's risk factors, such as housing, medical homes, and social services needs, like food insecurity. Each pathway addresses one risk at a time, and the completion of a pathway means that that risk factor was removed from the participant's life. Here you can see the list of the 20 evidence-based pathways that we currently use. Every risk factor is identified by completing a risk assessment, And then those risk factors are translated into a pathway. And by identifying risk factors such as the need for a PCP, food, behavioral health, and connecting those individuals to the resources to address those needs, like connecting someone to a medical home, SNAP benefit, or a behavioral health provider, we can see the larger scale outcomes from multiple risk factors being addressed, like reducing ER visits and hospitalization. We reduce cost of care, and the most important, we improve the health of an individual, among other great benefits for the person and the community as a whole. So some ways that we have helped advance health literacy activities and research. Currently, we're working in a pilot research project called Nourishing Beginnings. This 2-year research study is a joint effort among Better Health Partnership, Case Western Reserve University, First Year Cleveland, and Greater Cleveland Food Bank. The study is designed to test the feasibility and effectiveness of implementing a community health worker-led intervention to improve nutritious food access and consumption among pregnant people. The goal is to identify the most effective ways to support people during and after their pregnancies. Participants are asked a series of questions to help researchers understand the impact of the study. The participants have to be 18 years or older, able to read and understand English, and being enrolled in the Better Health Pathways Hub. So once the participant is enrolled in the Better Health Pathways Hub, participants are randomly placed into one of the 2 program study groups. So we have 2 groups. The first one is for participants to receive a box of food items delivered to their homes every other week by the food bank. The foods are fresh, unprocessed, highly nutritious, and customized based on the client's likes. And the boxes are also sized to feed all members of the household. This also offers an opportunity to provide monthly feedback from the participants to see which foods work and didn't work, and they can tailor that box as they like. The group 2 receive financial assistance for the purchase of food. So they receive money loaded into a cart every other week, every 2 weeks. And they also have access to a web-based food research tool. They receive training and assistance from the community health worker locating healthy foods options in their neighborhood. And all participants receive help with needed kitchen items and access to easy to understand recipes for healthy eating. We started serving clients in July of 2022. And today we have about 19 clients enrolled in the project, 8 in the catch arm and 11 in the food box arm. In the study, we have right now 5 community health workers who have received training specifically to work in this research study and the study protocol. And that's it for my short presentation. So thank you for listening. And if you want to learn more about Better Health, please go to our website, betterhealthpartnership.org. And to learn more about the Pathways Community Hub Institute, visit pchi.hub.org. Thank you so much. I'm going to stop sharing now. And I think, Jen, you're up.
Good afternoon, everybody. Can you see my screen yet?
Yes.
Okay. All righty. I'll kind of elaborate a little bit more on what Marie said. And as mentioned, I work at MetroHealth. I'm a nurse by background, and I manage some of our community health workers within the MetroHealth system. We have some in a couple different departments, and I'll elaborate a little bit more on where mine are focused. So just to go along with what everyone said, we really want to improve the health populations by leading efforts to address social and economic barriers to good health. So we're really creating an environment to empower our patients. The main goals of our community health worker program at MetroHealth is we want the patient to have improved health outcomes, reduce health disparities, lower the total cost of care, and we want the patient engaged in the community. So what does that mean for MetroHealth? So in a better sense, what we do with the patient, I'll go into each role and what each community health worker role within our institution does. But we are informal social support for the patient. And what I mean by that is if the patient's, some of the roles of our community health workers is just literally to give a patient a call weekly to check up on them. Hi, Mr. Jones, how you doing? How's your cat doing? Just a touch base with the patient. We found that helps keep them out of the emergency department. It helps them have a better connection with our health system. Just that call to check on them weekly. We do coaching. The community health workers are trained in their schooling to do some health education coaching. So our community health workers do some health coaching on attending doctor's appointments, healthy diets, things like that. We help them navigate the health system. We coordinate their care. We advocate for them. And overall, we help improve their access to care. So this is more the meat and potatoes of what we're here to share, what our specific community health workers do at MetroHealth. So I'm going to talk about 3 of our different community health workers: our OB community health worker, our emergency department community health worker, and our pediatric-led community health worker. So the OB community health worker at Metro, and I can't stress this enough about all the community health workers within the system, relationship building is the #1 goal. This role, we build trust with the patient. The patient ends up telling our community health workers a lot more than they're telling their physicians. They really, tell intimate details to their community health worker because they trust their community health worker. And that's what we want. That helps them stay engaged with their care and helps them follow up with their appointments because they really trust us. So the OB community health worker, this is for pregnant patients. They check in with the patients. They either do in-home visits or the patient will visit the community health worker before or after their OB appointment. If the patient might need some things to get ready for the baby, the community health worker will actually pick them up from a community-based organization and deliver them to the patient's house. We also attend community events. We work with a lot of community organizations within the Cleveland area. So if someone's having we had just a diaper event or a family baby, community baby shower, our community health workers attend those events and represent MetroHealth and talk to our patients and give little giveaways at those events. They look at their care gaps and update if the patient has, we're focusing on OB here, but if they notice that, they haven't been to the dentist, they'll make them a dentist appointment. Or if the physician has made some specialty recommendation to go see a pulmonologist, rheumatologist, anything like that, will help make those specialty appointments. We coordinate with other community programs, so Help Me Grow, Providence House, WIC, a lot of our community-based organizations, we connect. We're kind of the connector to connect our patient to those services. And what I like to explain there is we don't just hand out the phone number and say, hey, or here's the phone number to WIC, give them a call. Well, actually, we can go to the appointment with a patient if the patient would like us to. We can fill out applications with the patient, right in our office if they feel more comfortable doing it with us. We can really hold their hand through the process. And this, I think, is really what's made this program successful. We do a complete SDOH assessment, not only for our MetroHealth system, but also for the hub that Marie was just talking about. And we assist the patient with reminders about their appointments coming up. We can get them Lyft rides to their appointment. We help them with food. We help them with housing, baby items, short and long-term life goals. So if when we do that assessment in the beginning and we find out that they may not have graduated high school, we help them, sign up to get a GED. Or if they are thinking about long-term goals and they'd like to own a nail salon someday, like get them in the right path to finish those life goals and work on those life goals. And then lastly, financial planning. Where are they financially and what can we do with the resources we are able to offer them, and with planning, how they can do some financial planning. So that's the OB one. Then we have an emergency department community health worker. They do a lot of the same things. That relationship building, again, is key and #1 to this program working. They check in monthly or more frequently as needed. They do the complete SDOH assessment, assist with those appointments, reminders, and education, and help with kind of those same resources: food, transportation, housing, long-term goals, and filling out paperwork. The emergency department community health worker focuses on our high ED utilizers. So If they notice a Medicaid patient is coming to the emergency department frequently, we try to meet with them face to face and address their needs and concerns. If they need a primary care physician, if they need transportation, maybe they're coming in because they're just hungry. And if they tell the emergency department they have a headache, they'll come in and they'll get a turkey sandwich. So we try to really address those SDOH needs. And like I said, by building that relationship with the patient, finding out what their needs are and addressing those needs. And that, and the goal of the emergency department one is, again, to link them to primary care and help them use our emergency department more appropriately. And then lastly is our pediatric-led community health worker. She focuses on our pediatric population, making sure our Medicaid kids at age 1 and 2 years of age get lead tested, and then any child that does have an elevated lead level, that they do their follow-up. She assists with filling out applications for grants and loans to get their homes fixed up if there is lead found in the home. She helps with the lead inspections. And she does the same SDOH assessment in connection to resources that the other community health workers do. Her focus is lead, so she spends a lot of time working with the families to make sure they come in for their blood draws. If they're, working with landlords, working to get their homes tested for lead. We have a lead clinic at MetroHealth, so anyone with a lead TED or higher, she connects them to our lead clinic. She even attends those lead clinic appointments, so she's on the phone with them, but then she's also at the lead clinic when they have those appointments. And along the same line, she helps with those same resources: food, transportation, housing, goals, filling out paperwork, and delivering supplies to the home. As Marie had mentioned, so our community health workers work in the hub model. So I like to explain that the hub is kind of like a big database, a care coordination database. So if we do an assessment and we find out that the patient, has not been to the doctor's office in a long time, they haven't been to a dentist, they would like to complete school or go to college, or they need help finding a job, we do that assessment, and then as Marie mentioned, those pathways open up. So after the assessment is entered into the hub system, and we found that they don't have a primary care physician, a pathway will open up to try to get that patient a medical home, educate them about the importance of going to a primary care physician, getting them a ride to the doctor's appointment if they need it, and then having them attend the appointment. And that's how the pathway's closed. So when the pathway's closed, you've helped the patient connect to those medical services, and we implement that and then put it into this database, and then ultimately we get some reimbursement for the patient going to that appointment. So enroll, assess, plan, meet the patient, we track those outcomes, and then eventually get paid. These are just screenshots of kind of the work that they do within the hub. So this is kind of like on your left-hand side, a client profile. Then we do various tools. So everyone gets a PHQ-9 depression screening. And this is just an example of kind of a checklist. It kind of just is an assessment of what their general health is, any issues they have, so the community health worker knows what to focus her work on. Just to tie it back to research. So I know the question here is, how can community health workers help in the research era? And we are connected with Nourishing Beginnings in the Cleveland Food Bank in First Year Cleveland with the Nourishing Beginnings program that Marie mentioned. So I don't want to go over it again, but we're working with women 22 weeks of gestation or less, Medicaid patients. And we enroll them in the hub, that model I just mentioned. And a big part of the community health worker's role in the Nourishing Beginnings is obtaining consent to be in the Nourishing Beginnings program. And then she also kind of facilitates the whole process. So she completes a lot of surveys. She works in REDCap to complete those, send those surveys out to the patient. The patient does a cooking tool survey, a dietary recall survey, food preference survey, some other surveys and feedback surveys within the system. And the community health worker's role in this is that she kind of facilitates that. She makes the appointments, she sets them up, and she documents all of this in the hub as well. So we also can take credit for this in the hub as connecting them to resources, food resources. So again, this is really important that the community health worker builds that bond and relationship with the patient for this to be successful. So it's, we've worked with patients, we've developed that bond, and then they trust us to put them, help them with this program and help them with this program. So this, as Marie mentioned, they either get a food box or they're assigned to the Cash app. And that's, First Year Cleveland identified that nutritional deficiencies and long-term stress is one of the root causes for poor health outcomes in women. So the goal of this program is to find out which approach best benefits these moms and babies. So we're working closely with the Cleveland Food Bank. They've been really supportive and helpful with our community health workers along the way. And just like has mentioned before, our community health workers, their first goal is to help the patients with resources. And we do a lot of that, and we're proud of that work and enjoy that work, and the patients benefit for it. And then supplementally, we do these small programs like this, and help with the research projects. But it's been a great process so far. The patients are really liking it, and that community health worker, their relationship with the patient really is a good convener to get this work done. So. And that's all I have.
All right. Thank you so much, Jen. Elisa?
Hi, good afternoon. Pulling up my screen here. Are you able to see my screen?
Not yet.
Okay.
Perfect.
Okay, great. Good afternoon. My name is, sorry, I'm on the wrong slide. My name is Elisa Sprague, and as mentioned, I'm the program manager for psychiatry service at the VA. I've been at the VA for 15 years, and prior to that, worked for the Ohio Department of Mental Health for approximately 11 years, running community-based programs. I currently manage 3 of our community-based programs at the VA that specialize in working with veterans that are diagnosed with mental illness. We have community health workers that work throughout Northeast Ohio. I'm not sure how familiar people are with the VA, but we have outpatient clinics that are located throughout Northeast Ohio. So our workers usually are based out of those clinics so that we can provide services through all counties. For us, a definition of a community health worker is a person that provides person-centered care within home and community environments to vulnerable and marginalized communities, with the focus of attention being to assist them increasing their independence, stability, and overall medical and mental health outcomes. As noted, we have various disciplines and various degrees of credentials or none. The VA requires for social workers to have a master's level and then require an independent license within 3 years of hire. However, we have RNs, LPNs, peer support specialists, rehabilitation counselors, and vocational counselors that all have come with varying degrees of certification or licensure. So one of the things that we looked at was a contrast of how we describe community healthcare workers, and then how the National Institute of Health also describes. And they describe it as lay members of the community who work either for pay or volunteers in association with the local healthcare system in both urban and rural environments. They usually share ethnicity, language, socioeconomic status, and life experiences with the community members they serve. They have been identified by many titles: community health advisors, lay health advocates, promoters, outreach educators, community health representatives, peer health promoters, and peer health educators. For us at the VA, this more closely aligns with what our peer support workers do. And we do have peer support workers throughout all of our community-based programs. What we do, we provide advocacy, we act as liaisons, we connect to resources, we offer prevention service, we do safety referrals, we provide education and help navigate systems that the veterans would have difficulty doing on their own. We provide home-based mental and medical health services. The staff are familiar, the community workers are familiar with the cultural and nuances that operate within the community, the individuals they're working with. They collaborate with family, friends, and caregivers of the veterans they work with, traditional and non-traditional support systems, and they help remove barriers that prevent positive health outcomes, all while honoring the preferences of the veterans. Other keyword descriptions that we came up with were translating, interpreting, health promotion, health education, counseling, mentoring, social support, transportation, case management, and direct services. So essentially, we pretty much, we always at the VA, we kind of joke, if you need something done, just ask one of the case managers. We're out there, we're doing it, and we rarely say no to anything that the veteran needs to help them get the care that they need. And we've been asked sometimes, actually, even for veterans not in our programs, if we would check on a veteran that a social worker at the clinic was concerned about. And so we send out one of the case managers to do a home visit just to make sure that that veteran is safe. At Northeast Ohio VA, the case managers, as we call them, are the workers work as a middle person between the VA system and the veterans in their home and community. As many people know, the VA is a very, very large system with many resources and continually growing. So it's very difficult for people to keep on, for our veterans to keep on top of everything that the VA has to offer, who to contact when they need services. And so we bridge that gap. We also help to bridge care for individuals who may not engage in mental and medical health services by building trust and rapport. Our programs address needs such as homelessness, mental health, primary care, primary-based care, caregiver support, through programs such as our mental health intensive case management program, which is an evidence-based based on the evidence-based ACT team model. They provide intensive, frequent services specifically for veterans with a severe mental illness. We then have the community assistance program. This program is, again, community-based case management, less intensive, focused on those further along in the recovery, and it's intended to be 18 months or less before graduating from the program. By meeting their goals, by working with the veterans to meet their goals. The veterans must be diagnosed with a mental illness, but they do not have to be diagnosed with a severe mental illness. So we have some that are referred to this program with adjustment disorders, depressive disorders, etc. Our community residential care program is our VA group home program. So most of our group homes are state licensed, as most group homes in the community. We have a total of 52 group homes throughout Northeast Ohio, some as large that can take up to 80 veterans and state residents in their home, and others that will only maybe have 3 veterans in their homes. So they really vary based on the sizes. And those homes are each all monitored by social workers that are assigned to the homes. And then we have the medical foster home, and these are for veterans. This home is for veterans that need nursing home level of care, but prefer the home environment. So they would go into this person's home and live with them and get the care that they need there, along with our social worker that's assigned to that home and the home-based primary care team. I'll briefly touch on our comprehensive homeless programs. We have HUD-VASH, which is case management and like a housing first philosophy. We have our CRRC programs, which is walk-in housing support. And we have our home-based primary care teams and our PAC teams, which are our patient-aligned center treatment. So when you have a PAC team, you have everybody all on one team. You have your medical provider, your social worker, the nurse, psychologist, if applicable, but they're all on one team. So when you come in, it's that team that you're working with. And we have peer support embedded in all of our programs. The ways that we feel that we've helped advance health literacy activities and ideally research is we communicate health education in a common language in a way that is supportive rather than being perceived as authoritarian. So our veterans may be fearful of information from a doctor at a medical appointment or in a way that the information is interpreted due to the power differential with a doctor. The case manager may provide that same information in a more palatable way, leading to improved health literacy. The activity suggested by the case manager may be more readily accepted and attempted because the case manager may be doing or have recently done those activities themselves. So as a point of reference, travel training on public transportation, coming to a doctor for preventive health care, learning new ways to eat healthy on a budget after a diagnosis of diabetes, and et cetera. Research is supported by these efforts because we're engaging the clients in care and motivating them for follow through. This is the continuity of care for data outcomes. Case managers also make recommendations and identify gaps in services that need to be further evaluated and researched. This contributes to healthcare metrics that show us through our data at our own organization where we're getting things right, or maybe where we're not getting things right and what we need to do to improve. So in building relationships, we feel like it would be helpful if our community healthcare workers were recognized as a profession with specific well-known and understood standards to strive for. This would allow for some continuity to the role. There seems to be a lot of, as we've discussed here today, a lot of differentiation in what community healthcare workers do, how those roles are defined, some broadly and some more specifically. The continuity would allow for education to the role in a way that can be more standardized. Research is hinged on basic understanding of health problems with a question to explore about possible solutions or interventions. The community health workers are the conduit of health information to possible subjects in the field, but they're already in a position to market specific strategies to be measured. So the community health workers need the continuity and standard expectations of their role reinforced with solid clinical guidance at their place of work. Health equity can be achieved incrementally at all levels of the public health system. It should come from legislation and dedicated processes that are client-centered and motivated. Community health workers should be advocates, teachers, and mentors while we improve the system, sometimes through research and sometimes through litigation, and et cetera. Empowering veterans with community healthcare workers can be very powerful in getting the voice of the consumer at the table, which would ultimately support health equity for a larger population. So one of the major things that we do at the VA in order to try to make sure that the veterans are being heard is that they are on committees throughout our VA to ensure that their needs are being met. We're hearing what their experiences are and that we're making adjustments specifically based on their recommendations. And again, this would be something I think that we feel would be really helpful for research to also make a consideration. Another suggestion was for researchers to spend time in the field with community health workers, kind of shadowing, observing practices, and also providing outreach and education opportunities to the community health care workers. And that is all I have.
All right. Thank you so much, Elisa, Jen, Marie, Odiri. Lots of information here and great actionable feedback and items that our research community can take back and implement in their research. Do we have any questions in the chat or anyone who would like to come off mute to ask a question? What would you all say is the, I guess, biggest pet peeve when it comes to the research community engaging community health workers? And I know that this was touched on, but I just like to elevate it because as we move forward, we're seeing a lot of grant opportunities that are highly recommending or strongly recommending, if not mandating, that individuals, research teams are working with community organizations. And anything with community is pretty much fair game in terms of trying to integrate that into the already existing studies. So I heard some really great tips about involving community health workers at the beginning when the study is being structured and framed. What kind of comes to mind?
Yeah, Giselle, to that point, we did include CHW's feedback when developing the research. And two, one of the ideas behind it was that having a community health worker who already has a trusting relationship with the participants can help engagement through the research project. Oftentimes you have participants that kind of fall off the research study. So having someone that they already kind of trust in the process might help the research study to be more successful.
Yeah, I would agree with Marie's comments. I think it's just the most important thing, or one of the most important things to do is just make sure that community health workers are part of your research implementation. They are not just, you know, the checkbox to say like we're working with community health worker and this is how we're using a community health worker in this space. They are actually active members of the research team in their own scope of practice, in their own respective right. And I think that just goes back to really understanding what is a community health worker, what do they do, how can they be integral to the research that's still in their scope of practice, and actually recognizes them as their own profession.
And I completely agree as well. And I know we've done a couple different research projects, and the feedback we got from the community health workers was that, you know, I wish I could have been a part of this when you were developing this program, because I would have gave you a little bit different insight. So great. And they felt more valued when we did that. If they're going to be part of this research project, then I think they felt more valued if we would have brought them in earlier and kind of not afterwards when we developed everything and then kind of said, here's what we want you to do. They felt more valued. And just to keep in mind as we do this along the way, their primary goal is to build that relationship and connect the patient to resources. So their primary, you know, although they help with research and they're definitely partnering and it's wonderful, their primary goal is to connect them to resources. So just to always keep that at the forefront in everything we do, because that's what their main goal is for. So yeah.
Absolutely. And then as a final question, getting back to ensuring that community health workers are a part of the conversation at the beginning of the conversation when developing a research study, how can researchers get in touch with each of your community health worker programs? And, you know, what's the best way to reach out?
For me, I've recently transitioned into a different role than the community health worker program, but I'm happy to connect anyone who's interested. My contact information is, I believe it's in the email invite. If not, I will drop it in the chat and maybe Jaleese, you can put it out, but just a simple email.
Yes, I'm here. I mean, I'm, you know, there's no wrong door in Better Health. So anybody at Better Health Partnership is the right door, but you can feel free to reach out and inquire about how we can partner.
And say my email's on there, and Marie and I work closely together too. And we do have other community health workers within the system. We have some in school health, and a couple different areas within the MetroHealth system. So I just kind of focused on the ones that I work with. So if mine would work for a research project, we'd be happy to partner with you, but we also have other teams as well.
For the VA, I would be glad to connect people either with my teams or with program managers that are overseeing the PAC teams or the homeless outreach programs. So I will drop my email and phone number into the chat.
All right, thank you all so much. So what's next? We have our third READI Community Engagement Talk, Equity and Engagement, Developing the Path from Community Researcher to Co-Author. That'll be held on Tuesday, May 2nd from 12 to 1, also on Zoom. And we have presenters from outside of our local area. So that'll be really intriguing to see how they navigate this and have explored it in their research. And what can you do today? You can schedule a READI consultation at spark.case.edu. And you can sign up to attend future programming and join our listserv. So we not only have READI Community Engagement Series talks, we also explore special populations on a monthly basis. And we talk about the impact of research on policy. So very important there, and a great opportunity for everyone, all stakeholders that are interested in that. And you can review our CTSC DEIA resources on our website. We'll give you a couple minutes for virtual commute time, engaging meaningful activity that will help you commute back to yourself. Move, breathe, engage your senses. And that's a term coined by Dr. Jennifer A. King. She's here at CASE. Thank you so much for joining us.
Hi, I have a question, last question before
Sure.
we go.
Please.
I'm Cynthia, I'm from Cleveland Clinic, and I'm an early investigator. So I'm kind of new to this, and I'm planning, one of my goals is to apply community participatory research in my work. So this is a question for the social workers, is the type of work or service that you provide is tailored based on the specialty? Like, for example, I'm pretty sure like in sleep medicine, we don't have, I don't know any institution or any, I would say, yeah, any institution that works with community health workers in our specialty, and likely the needs of our patient population tailored to a sleep medicine is different from, primary care or cardiology. So is there, the service is tailored towards the specialty? I know that it's tailored toward the needs. I don't know if I'm.
I'm actually mentally peering it to a project we're working right now. It's not a research project, but it's similar. It's providing services to stroke patients and that are kind of moving from rehab back to their home. And we're connecting those stroke patients to a community health worker to help them navigate their social needs as they go back to regular life after having a stroke. So we do train the CHWs in stroke-specific education and stroke-specific needs for them to be able to help those patients. So I'm sure that could be tailored into a research study. Where the same for the Nourishing Beginnings project. We have community health workers that specialize in providing services to pregnant people. So they know what a pregnant person is going through and what they need.
Yeah, thank you.
Mm-hmm.
Right. Thank you so much for that excellent question. Thank you again to our presenters, Marie, Odiri, Jen, and Elisa. We really appreciate it. We hope that you'll be flooded with inquiries from our research community. All right, everyone, have a great afternoon, and please complete the post-webinar survey that's in the chat. You'll also receive an email after this. All right, have a great afternoon.
Thank you.